In any given week, the Prairie Heart Institute at St. John's Hospital, one of the largest heart centers in the Midwest, will treat a remarkable number of patients with an astounding variety of conditions. We randomly chose a week in December and stationed our videographers there to document patients' experiences in a given week. We met Mabel Canute of Frederick, who came in on Sunday night because she was lightheaded and her pulse rate was low. And Tom Kammerer of Grafton, who got some very disturbing news that may have saved his life. And Walter Weiberg of Clinton, who was a candidate for a rather new procedure because his aortic valve was shot. And many others. You will hear from them and their doctors, and you will relive their experiences of this week. For most of them, their journey starts in the cath lab prep area.
Their journey starts here in their pre-cath area. So this entire area is all the patients who are waiting to have a catheterization procedure and then being brought back here after they recover.
Mm-hmm. And in the case of Prairie Heart, for instance, there'd be dozens of people a day go through this place and get set up and then go into the cath lab, wouldn't you?
Correct.
Yeah.
Certainly a couple dozen.
Busy place.
At least a couple dozen, and then of course emergencies that might be coming up through the emergency room as well.
Mm-hmm. Their treatment plan will eventually lead them to the cath lab, where cardiologists will get a look into their hearts using a catheter that is guided through the vessels. The process, called an angiogram, helps the cardiologist diagnose what and where the problems are. 84-year-old Anna Barker of Mount Sterling has had her angiogram. She has recently had stomach pain, been unable to eat, and has lost a lot of weight.
Started out, I didn't have any appetite, and I've lost about,
30 pounds.
Well, not at this time.
30 pounds.
I'm down to 105 pounds, and I weighed 100 and around 125 before this.
Okay.
And you just hurt all over. You hurt. Ache.
Where does it hurt?
Your stomach, and you shake. It never just shakes constantly.
Your stomach hurts and you have the shakes and you've lost weight.
Yes.
And your doctor Goswami has just come into the room.
Yeah.
So this is a real good time for us to be here. And what does he tell you is wrong, and how does he want to help you?
I have a blockage in the main artery. Let him tell you.
I'm gonna ask him a little bit later, okay? But it sure is nice that he could come in right now anyway.
You tell. I've got a blockage in the main artery.
You got a blockage in the artery that feeds part of your gut. And so that's kind of what we're thinking may be wrong as to why you're losing all this weight. And hopefully if we can put a stent in there and open it, that'll all get better and you can eat without having much trouble.
Mm-hmm.
So that's why you've lost all this weight, is because you can't eat because it hurts, huh?
You can't, you just don't have, food just sounds terrible.
Mm-hmm.
So that's a pretty classic symptom of this particular condition is, it's called cytophobia. So actually, that's literally translates to fear of food or fear of eating, because she knows every time she eats, she's going to be miserable.
Sure.
So they just stop eating. Mm-hmm. And you've lost how much weight?
I'm not really for sure.
About 25 pounds altogether.
25 pounds in a month and a half or something like that?
Yeah. That's too fast.
That's a lot, especially a little lady, you know.
Look at my skin, yes, you can tell I lost it.
Yeah. So which is the artery that you're going to try to open up?
Well, there's two. There's one for sure, the celiac artery. So that's an artery kind of in the mid-abdomen here that feeds the gut. And that one we know is very tight, over 90% blocked. And then there's an artery right below it called the superior mesenteric artery that also appears to have at least moderate, if not more, and we're going to interrogate that a little bit more today, and if that needs a stent, we're right next to it, and we'll just take care of that as well.
And you can do that in the cath lab without having to cut into her. You
Correct, yeah. Actually, for her, I'm thinking about going through her arm right here, and then we'll go down into those vessels and do what we need to fix it.
About this time, 62-year-old Tom Kammerer of Grafton is getting ready for his angiogram. He wanted a back operation to relieve back pain, but his EKG wasn't normal. In the cath lab, Dr. Mischkel will find out why. So, Mr. Kammerer, you were actually going to have back surgery, but as a matter of fact, what happened to you was they found something irregular with your heart and didn't want to go through with that. What happened in the testing process?
The EKG wasn't, on the left side of the heartbeat wasn't right.
Mm-hmm.
And so then they referred me to Springfield, which
Mhm.
I have my back surgeries done up here. I've had 4 back surgeries.
Oh man,
That
so
was
your
gonna be
back
my-
has been
Yeah.
bad for a long time,
Yeah,
huh?
this was gonna be my 5th. And when the EKG come up not right, they referred me to Dr.
Mm-hmm.
So,
Mm-hmm. So on this day, what you're going to have, you're going to go in and you're going to get a cath. You're going to get your to find out if you have any blockages or
Right.
see any
Right.
irregularities,
Right.
and they're going to do that in the cath lab, huh?
yes, they're
Okay.
doing a cath, and then if they can fix it with a stent, they'll do the stent. If not, then they gotta reschedule.
Mm-hmm. Have you ever been in the cath lab before?
No.
No. Your heart's always been just fine, as far as you know, huh?
Mm-hmm.
What do you think about going into the cath lab? Are you apprehensive or scared at all?
No, I just want to get it fixed.
Just want to get it fixed, huh?
Mhm.
Yeah. Have you ever known anybody that's been through this process?
My folks, both of them.
Oh, really? Yeah, they both had heart issues. Huh?
Yeah, my father's had stents, and my mom's had open heart.
Mm-hmm.
So,
Mm-hmm. Are they still with us, or they passed away?
in '84, both of them.
They're still with us, huh?
Mhm.
Okay, so they've had good care, haven't they?
They was done up in Springfield too.
Mm-hmm. Well, terrific, terrific. So you don't have any apprehension about this? You're ready to go and get it done, and if it takes a stent or two, you're good with that,
Yeah.
huh? So you can get that back surgery again.
Yeah, I can't hardly walk, so
Oh, man.
so
Yeah.
try to get the back fixed so we can get
Mhm.
going.
Yeah.
But I wasn't expecting this. I was going in for an oil change, now I'm getting a new rear end.
While they prepare to load Tom in the cath lab, Dr. Goswami is at work on Anna Barker, locating the abdominal artery that is blocked. When he is certain where the blockage is, he will choose a stent that will be placed in the artery at the blockage point, inflate it with a balloon, and then it will be left there to prop open the artery. Blood flow is increased immediately. With the use of ultrasound, you get the view as though you are inside the vessel looking downstream toward the stent.
That's an ultrasound catheter within the artery itself, and it's giving us that image there on the upper right. So we're going to pull back into the stent here, and you can see the bright white markers are the stent. And the stent looks like a good size. All the stent, the bright white areas are touching the vessel wall, which is what we want. And the area that was constricted now is relieved. Looks pretty wide open, so very nice result.
Meantime, Dr. Mishkel is examining Tom Kammerer to find out why he had an abnormal EKG.
So this is a radial artery puncture. We used to do most of the caths from the groin, but it turns out it's a little safer actually to do it, a little harder, but a little safer to do it from the wrist. And so believe it or not, we can get to the heart from the wrist. So we do a little puncture into the right radial artery there, put our wire in, and then we put our sheath in. Comes out. Then the next step is we take a little cocktail. Becky, thank you. It's a little early in the morning for a cocktail, but it's not for me, it's for him. And this is a combination of blood thinner and an antispasmodic to prevent the artery from spasming, because it's such a small artery when we put our catheters through. And it's a sort of acidic, pH is lower than the blood, so it oftentimes can cause some discomfort, so we buffer the solution with his own blood to raise the pH up and make it a little bit more tolerable. So now we have our sheath in the wrist. The patient is comfortably snoozing, imagining he's on a beach. And we're going to go ahead and pass our catheters up to the heart here.
It's becoming clear after looking at his heart from a number of angles that Tom may have advanced heart disease.
And I'm going to swing this catheter around, and there it is. And you can see the calcium at the tip of that catheter. So that's the left coronary artery. So what's happening now is the camera is swinging around the patient. So imagine that the heart is a car,
And we want to look at every part of the car. We want to look at the hood, chin. We want to look at the windshield. We want to look at the side windows. We want to look at the trim. It's like when you rent your car. You want to make sure from every aspect, front, back, top, bottom, right shoulder. So we see an awful lot of calcium in the arteries to his heart there. So you'll see right at the very beginning, before the dye actually goes in, this area here where you can actually see hardening of the arteries. So that's what we call hardening of the arteries.
As soon as the angiogram is complete, we go to take another look at the results.
I mean, this is the sort of area that you hear that term widowmaker. That when you have these narrowings that start right at the very beginning of the artery, you kind of get the impression right up in there is, see how narrow it is?
Yep.
And this, I think, is a big chunk of calcium there, and then it's very tight. I don't often, be melodramatic with patients in terms of, hey, you need to have this done to save your life or whatever, but this sort of anatomy, I don't think, I have to admit that as I look at this, I'm starting to think, even though he's relatively asymptomatic, I'm starting to think he needs bypass surgery. Now the good news is that he has good target vessels, meaning that there's good vessels for a surgeon to tie into, and he has normal heart function. So now we've swung the camera over to the right coronary artery, and remember that's the one that had the collaterals that were coming in here, and there is just a string there. Do you see that?
Yes, I do.
So there's that's probably a ruptured plaque, and there's just, the red blood cells are lining up one by one to get through that narrowing. Very, very tight. So he has what I call proximal three-vessel coronary disease, meaning a lot of it's upstream. And now the good news is, I'm not sure which direction we've gone here. The good news is, his heart function, we don't have that up yet, hasn't been transferred over. But we know he has normal heart function, and good target vessels. So I think what we need to do now is go talk to him about what we've found. There it is. Okay, let's go chat with him. Okay. So your wife has the pictures, and so this is kind of a good news, bad news scenario. The bad news is you have, for a guy who is relatively asymptomatic, a lot of heart disease. So now, what could possibly be the good news? The good news is several-fold. Number one is we found it. And you're not going to be a statistic. Because particularly in people who have minimal symptoms, oftentimes you don't find this until potentially somebody has had an event. Nurse just needs to get through here in a sec. So that's number one. Number two is that you have had no damage to your heart. So despite the fact that you have all three arteries narrowed, you have no damage. And the third piece of good news, to offset the bad news, is that it's fixable. But it does need to be fixed. So if we go through looking at the anatomy, this is in fact the artery here on the right side that lit up on the stress test that gave us the clue that there was something amiss. But on the other side of the heart, you have areas of narrowing in the artery that goes to both the back part of the heart as well as the front part of the heart, and then further downstream. In the vernacular, oftentimes people call this type of anatomy the widowmaker, because it's all upstream. And I just don't think that this is a scenario that you can go and have an elective back surgery without getting this fixed. I don't think that this is a situation where just putting you on medicines is going to be sufficient. And I think that and in terms of fixing it, it's really too much for stents. I think you need to have open heart surgery. Actually, I kind of more than think. I know.
While Tom is digesting this difficult news, 87-year-old Walter Weiberg of Clinton is being told he's a candidate for a rather new procedure known as TAVR, or transcatheter aortic valve replacement, replacing the aortic valve using a catheter instead of open heart surgery. Prairie Heart Institute is a pioneer in this procedure. Walter had triple bypass surgery in 2005, but now his aortic valve is not opening properly. Dr. Jeffrey Goldstein explains.
So what we're going to do is talk about the problem you have and the procedure that we propose for tomorrow, okay?
Okay.
Do you have any questions before we get started? Maybe questions right off the bat?
Not really. No.
Okay. Well, the problem you have is aortic stenosis, right? You understand that? And the aortic valve is the valve that opens when the heart squeezes. Can I borrow your model, Shelley? And the stents in the... Does this come out? No. The aortic valve is the valve that opens when your heart squeezes and allows the blood out of the heart so it can circulate to the rest of the body. As we get older, that valve can get worn out and it doesn't open as well. So instead of doing this, it kind of opens like this. Okay? And it's kind of like a clogged fuel line in your car. It'll allow a little bit of gas to get through, but when you try to accelerate, you know, the car kind of sputters, and the same thing's happening with you. Right? So there's a couple ways to fix the valve. One way is to do open heart surgery, where we open your chest, we open the heart, we take out the old valve and sew in a new valve. Okay? For patients who are at increased risk for that kind of procedure, the TAVR, or the transcatheter aortic valve replacement, is a newer procedure where we...
Pardon me, I didn't get that.
The stent valve, the TAVR, transcatheter aortic valve replacement. That's what TAVR stands for.
Okay.
That's the stent valve. That's a newer procedure, and that's what we're talking about for tomorrow. It allows us to put the valve in without opening your heart up. Okay? So a lot of times we can go from an artery in your groin, and with the valve on a tube or a catheter, we can thread it up to your heart, and we can inflate the stent or deploy the stent where the old valve was. Does that make sense?
Yep.
Okay?
As Walter gets ready to be admitted, it's time to check on Anna Barker, who's had a day of rest after the stent was placed in her abdominal artery. Remember, she hadn't been able to eat and lost 20 pounds. We discussed before the procedure that you lost a lot of weight.
Yes,
in the last few months. How much weight had you lost?
around 20 pounds,
Around 20 pounds?
Uh-huh.
And why?
because I couldn't eat.
It was just,
And-
you got cramps, or it was painful? Or?
It was painful and no appetite. And he said because my stomach was hungry for blood and it wasn't getting it.
Oh, I see.
And he said, and when I did eat, it didn't do any good. So,
Yeah. But and the doctor also said that you'd almost immediately be hungry.
Yeah.
Right? And what was it like yesterday after the procedure?
well, I got hungry and I ate supper last night. And I ate breakfast this morning. So
And no pain.
no pain.
And
no.
you'll be hungry at noon probably. huh?
Probably.
So here's the picture after the stent's been placed, and you can see actually this steel cage is the outline of the stent here. This is a catheter. Now, we did this procedure from her arm, and so I'm coming from above here. And you can see that little small string has now become this vessel that's this size.
Look how wide that is now.
More appropriate, I would say.
That'll
in
carry
size.
some blood, won't it?
Yeah, it should carry much more blood. And clearly her symptoms have improved to the point where she's eating stir fry on a nightly basis now.
And loving it. Tom Kammerer and his wife have decided to go ahead with the coronary artery bypass surgery. The term widowmaker is persuasive language. Dr. Mischkel has arranged for Dr. William Stevens to perform the operation. If all goes well, he'll be going home in a few days. Walt Weiberg is ready for his new aortic valve. Until 3 years ago, he would have had to live with his fatigue, shortness of breath, and that ever-present sound of his faulty valve. The TAVR procedure is rather new and especially beneficial for those of advanced age who are not candidates for surgical replacement.
Right now you have the stent valve here. It's collapsed around the balloon. Okay? So this stent will be advanced across the aortic valve, which is currently narrowed. And we will inflate the balloon, which will expand the stent and lock it in place, pushing the leaflets from the old disease valve to the side, and the new leaflets are suspended in the middle of that stent ring.
In an hour or so, Walt should be ready for recovery. Tom Kammerer's bypass was successful. Recovery from that, of course, is more painful and takes longer.
So, surgery, this is your first day after surgery. How you feeling? Feel okay so far? Well, you're smiling. That's a good sign.
Yeah, I'll be fine.
You will, absolutely. You look good. Your color's good. Everything.
I've
Your
been
blood pressure's
suntanned.
great. What's that?
I've been suntanned.
I can tell. You went last night too, didn't you? To that tanning bed. Yeah. You really do look good though.
No, they've been taking care of me right away.
Taking good care. Yeah. Are you having any shortness of breath?
No, I'm saying everything's fine.
Good.
It does hurt bad.
A little
up here.
sure. That's to be
I
expected.
know where you got them things.
Right, that's right.
I know.
And we want you to keep doing your deep breaths and your coughs. You know, it's very important to keep your lungs aerated and to keep everything, those deep breaths make all the difference in the world, okay?
Back to Mr. Kammerer again.
Yes.
You know, we visit with him afterwards. He's speaking well. He
Yes.
looks his color. He has
Yes.
color in his face. He looks
Yes.
good. What can he expect after next few days or so?
Well, the next few days, like today, we'll get he has a bunch of, you probably noticed, a bunch of lines and tubes and wires in. He'll get a bunch of those out today. I'll take his chest tubes out. He'll get a bunch of the drips off today. And then he'll move to our step-down unit on the 4th or 5th floor of the main part of the hospital. And that's where he'll stay till he's ready to go home. But we'll get him up and get him walking some. A little bit today, but more each day. He's got to work on his incentive spirometer. I always tell him there are 3 jobs. They're working on that incentive spirometer, breathing machine, trying to eat as best as they can, and that's a struggle a lot of times after surgery. And walking. Those are
Eat,
his
breathe,
jobs.
and walk.
You got it.
Right? Okay.
Yes.
The day after his valve replacement, Walt Weiberg was sitting up, having lunch, and feeling pretty good.
Do you believe your valve procedure was just yesterday? Not only just about 24 hours ago.
Yeah, just about.
Are you having any chest pain?
No,
How's your breathing feel?
better.
Have you noticed a difference?
Oh yes.
Already?
Already.
Okay. Any other problems?
No,
Do you mind if I take a listen to you?
no. You're the doctor.
He was actually asking for Jeffrey.
There we go. But it was his
He
son.
wanted to shake Jeffrey's hand.
I got a world of faith in you.
But take a listen. Yep. You remember that murmur we listened to yesterday?
Yeah.
Yeah, I know you couldn't hear it, but it's gone.
Well, I heard of that.
Have you had him listen?
Yeah.
Okay. Yeah, it's gone now.
It's gone, huh?
Lean forward.
Well, that's
Deep
good.
breath. Yeah, so that narrowed aortic valve, when the heart has to pump really hard to get the blood through that narrow opening, the end result is turbulent blood flow, and that's that murmur that we heard yesterday.
Oh.
Now we've relieved that narrowing. You have normal flow through the valve, and the murmur is completely gone.
And I've had that murmur for many years, and you fixed it just like that.
Now it's just a memory. All right, buddy. I'm glad you're doing better.
I am too.
Don't do that. You're going to make me cry. So what you see right here is you can see the stent valve in position before it's inflated. Now what we're doing is we're inflating the balloon, and that has the effect of expanding the stent, displacing the old calcified diseased leaflets out of the way, and the new functioning leaflets are suspended in the middle of this valve. So what we've done is we've displaced the old leaflets, we've opened up that opening, and the new functioning leaflets are in the middle of the stent valve.
And the old valve just stays in there.
Yeah, it has enough radial force that once that stainless steel frame of the stent is expanded, it grabs on, if you will, to those diseased leaflets in that opening, and it stays suspended there, holding the new leaflets in place.
I guess the real challenge to this procedure is making sure that you've got that stent right where you want it, right in that valve opening.
That is the crux of the procedure, is making sure that that stent valve is exactly in the appropriate valve plane between the aorta up here and the left ventricle, the heart down here. It must be right on that plane right there.
And most of these patients are elderly, so this valve is going to last them the rest of their life.
That's the expectation.
Do you remember what your heart sounded like before we fixed?
Yeah.
Yeah. You want to hear it now?
Yeah.
Okay. Let's get your ears put on here.
That's impossible.
That noise is gone, isn't it?
Oh, completely. Oh, it makes me happy.
Walt is going home, but other patients' journeys are just beginning in the next edition of Cardia in Any Given Week.
For a DVD copy of the program you've just seen, send 1995 to Network Knowledge, P.O. Box 6248, Springfield, Illinois 62708. Be sure to include the program name, subject, and when the program aired. You can also order with your credit card by calling 800-232-3605.